Welcome to lecture for psychopathology. Right now I'll be talking about mood disorders. Before we start talking about the disorders per se and the diagnostic criteria, first it's important to clarify a few terms that you'll see used throughout this section. Terms that are sometimes used interchangeably in other settings, but may have important differences in meaning when it comes to psychopathology. We start with emotion. So this is a state of arousal defined by subjective states of feeling and patterns of physiological activity. An emotion is usually a response to something, right? You have an emotional response, and it can be to a variety of things. It can come an external stimulus, internal stimulus. So thinking something a certain way, remembering something can cause emotion. Seeing, hearing, smelling something might give rise to this subjective state of feeling, which again is associated with usually a characteristic pattern of physiological activity. With fear being an emotion, where you have accelerated heart rate, release of adrenaline, those types of things. Right? Happiness also seems to have less well-defined, but still some characteristic physiological markers. But the key here is that the subjective state of feeling, really, because the patterns of physiological activity, there's a lot of overlap between them. Sometimes, feeling an intense emotion, physiologically, it looks the same for different subjective states. So, intense happiness and intense anger, some physiological markers may look very similar. Right? You may see an increased heart rate with both of those. But subjectively, they're very different, and that's why we label them differently as different emotions. So again, emotion means kind of a short-term, relatively, state of arousal. So you have kind of baseline going through life, and this is a bit more. So more happy, more sad, more something. And there's a subjective state where you kind of label it, I feel differently. Affect, on the other hand, is a pattern of observable behaviors, like facial expressions, body language, kind of posture, that are associated with subjective feelings. So when we talk about observing someone's affect, we're talking about those external indicators of what we believe to be their subjective feelings. And affect is a word I think really is used interchangeably, even in psychopathology. Usually we talk about the observable behaviors, especially when diagnostic criteria, we talk about flat affect. That's about what you see, not what they're experiencing, per se, because you can only guess what they're experiencing. But sometimes you'll read articles where they do talk about a person's experience of affect, and not talking so much about the observable behaviors, really talking about emotion. But in the criteria, usually it's what those observable behaviors that we're looking at. We're talking about somebody's affect being flat or inappropriate or appropriate, those types of things. Mood, it's kind of like an emotion but spread out. Right? So it's a pervasive and sustained emotional response that may affect a person's perceptions, may color how you see the world, what information you choose to intake, that you choose to process, and choose here, not even always assuming a conscious effort. Right? This is the idea that when you're depressed, you're more likely to notice and think about and observe and take in depressive stimuli, and more likely to ignore happy stimuli. So if you're feeling depressed and you're in a depressed mood for some period of time, and somebody tells you, hey, you did a great job in that thing, there's just one thing that was a little off. You'll hear there was one thing that's a little off. People ask you later, well, did they like it? You say no. You won't remember. You won't attend to that positive feedback. You'll disregard, disown that stuff, and only bring in the negative. Same thing with other mood states. When people are irritated and angry, it's easier for them to pick out other angry faces in a crowd than it is to see happy faces. So the terms we use for mood in psychopathy, depressed mood or dysthymic mood, those are often used interchangeably. And then elated, manic, and euphoric, all meaning good mood generally. With elated and euphoric having a very kind of positive connotation. Manic, sometimes used interchangeably with those, but a more broad term. somebody could be manic and not really feeling good, so you can be irritable and manic. But you think about the difference between dysthymic mood and depressed mood, think about energy level. So if you're in kind of depressed dysthymic mood, it's low energy, and elated manic euphoric is high energy. We also see the terms dysphoric and euthymic. Dysphoric being generally negative, and euthymic being normal mood, kind of typical appropriate mood. Not real happy, not real sad, just kind of okay right where you are. That's euthymia. Okay, just an overview of the DSM disorders. Because when we get down to the criteria, it's all the disorders defined by the presence or absence of certain mood episodes. Right? So major depressive disorder requires the presence of one or more major depressive episodes without a history of a manic, mixed, or hypomanic episode. Okay. So that means right now the person that you're having to diagnose either is experiencing a major depressive episode, meets the definitional criteria for what that mood episode is, which we'll talk about in a minute, what it takes to say somebody has experienced or is experiencing a depressive episode. So they have it right now, they've had it for long enough that they meet criteria, or they've had it some period in the past, and they've never had any other kind of mood episode. Once you add any kind of mood episode to depression, it changes the diagnosis to a bipolar disorder. Okay, so a major depressive disorder is kind of pure depression, and sometimes you see it referred to as unipolar depression, meaning only depression and no mania, no hypomania. Bipolar 1 disorder, because bipolar disorder is split into two categories right now. Bipolar 1, one or more manic or mixed episodes, and as we'll talk about in a little bit, a mixed episode is when you have all the manic symptoms and the depressive symptoms in the same short period of time. So pretty much you have to have all the symptoms of mania at some point, either as part of a mixed episode or as part of a manic episode. So again, currently or history. And then a major depressive episode may be present currently or have occurred in the past. Right? So for bipolar 1, you have to have a manic episode or a mixed episode, and that's it. You don't ever have to experience depression. Okay. Most people with bipolar 1 disorder have experienced a depressive episode. If they haven't yet, so if you're seeing them in the first time they're manic and they've never experienced depression, wait, and eventually they most likely will experience a major depressive episode or some other mood episode. It's uncommon to just experience mania in normal mood and never dip below the line. Okay. But technically not required. You could just have a manic episode or just have a mixed episode and you have bipolar 1. Okay. That's when you meet full criteria for a manic episode or mixed. Bipolar 2, slightly different, kind of less mania. So this is where you are now required to have one or more major depressive episodes with at least one hypomanic episode. So this is where somebody hasn't had a full manic episode or a mixed episode, so they haven't been fully manic yet, but they've been a little manic enough to meet criteria for a hypomanic episode currently or at some time in the past. But just being hypomanic by itself isn't enough to get you a diagnosis. Unlike mania, if you have full-blown mania, full-blown manic episode, bipolar 1. If you have full-blown hypomanic episode, which hypomanic being less than manic, hypomanic, right? If you have a hypomanic episode by itself, it's not diagnosable. You're just in a really good mood, right? And sometimes if you drink, a lot of coffee, you may get a little hypomanic. I know I do sometimes. But if you have that and you never experience a major depressive episode, not a diagnosis. But if you do experience a major depressive episode, right now or in the past, it's bipolar 2. And again, many people with bipolar 2 go on to switch diagnosis to bipolar 1. Because once somebody with a major depressive episode and hypomanic episode, both of those sometime in their history, once that person experiences either a manic or mixed episode, then that diagnosis no longer applies and it converts to bipolar 2. Okay. And really, I think the reason sometimes we don't see that is that people stay on their medication. They've been depressed, get a little hypomanic, they're bipolar 2, they get put on medication, and they never are able to be fully manic if they stay on their regimen. Okay, so we have major depressive disorder, MDD, two types of bipolar, bipolar 1 and 2. One is, full mania or a mixed episode. Bipolar 2 is hypomanic with a depressive episode. And then we also have cyclothymic and dysthymic disorders. And in these, you don't have the full mood episodes. You might have hypomania, a cyclothymic disorder, but you'd never meet you don't have a full-blown mood, a full-blown major depressive episode or manic episode or mixed episode, with some exceptions, which we'll talk about in a little bit. But these are your kind of longer-term mood disturbances, where cyclothymic being akin to bipolar disorder, where you're having these fluctuations where a little bit manic, a little bit depressed, but never manic enough to be fully manic and never depressed enough to be major depressive disorder. And dysthymic disorder being more akin to major depressive disorder, kind of this long-term period of low-level depression, where it doesn't quite reach that tipping point to be a major depressive episode, but it's kind of always depressed. Okay, so now we've given that overview of what the major mood disorders are. Let's talk about what the symptoms are for a mood episode, because that really tells you what the... Okay. A major depressive episode, which again occurs in major depressive disorder and in bipolar 2. So you have to have 5 or more symptoms present during the same 2-week period. So it's not like, oh, I had this, and then that kind of went away, and I felt happier, but then I started crying, and this. No, it's during this same 2-week period. You have 5 symptoms, and it represents a change from previous functioning. So it's not that you are always this way. As we'll see, depressed mood almost all the time is one of the symptoms. And if you've always been depressed, we're thinking more dysthymia. This is an episode is your mood is somewhere in that normal range, a little higher, a little lower than typical, average, whatever, and then boom, something happens and it drops, right? So it's a change from previous functioning, and at least one of the 5 symptoms is either depressed mood or loss of interest or pleasure in previously enjoyable events, which is referred to as anhedonia, right? It's depressed mood or anhedonia. Okay, so the symptoms you can have: depressed mood almost all of the time. So we're talking about this being nearly every day or all day for 2 weeks. And then in youth, people under 18, instead of depressed mood, irritable mood can be substituted to meet criteria for major depressive episode, with thinking being that it manifests differently in youth. Debate about that, but that's what it is right now. Anhedonia, or diminished interest or pleasure in almost all activities, almost all of the time. So this isn't like, oh yeah, really, I'm not interested in doing my work because work sucks. It's diminished interest or pleasure in things that should be interesting or pleasurable. So things, yeah, I really am not interested in cleaning the toilets. Okay, well, that's not necessarily a symptom of depression. This is where things that are enjoyable and that you kind of find interesting and intriguing, you just don't anymore, right? So going out with friends, talking to people, even playing video games. Sometimes you see people just, they're just not in the mood anymore. I used to love this game, now nothing seems like fun. Okay. So that's what we're talking about. Significant change in weight or appetite. This is either increased weight or decreased weight, increased appetite or decreased appetite. So just a change that's, again, significant, from a change from before. All of a sudden not hungry, or all of a sudden hungry all the time. More common to have a loss of appetite. Insomnia or hypersomnia, so we have this disturbance of sleep. Again, we're either not able to sleep or get enough restful sleep, or sleeping all the time. With more common to see insomnia. And you think about people, oh, they're depressed, they stay in bed all day. Yeah, they may stay in bed, but they're probably not sleeping. That's probably why they're in bed, is because they didn't sleep well the night before and can't get to sleep and don't have the energy to get up and do anything. But at the same time, can't sleep, which is really difficult. Psychomotor agitation or retardation. So psychomotor psychomotor agitation obviously being kind of sped up, which is atypical for most people with depression. More likely to have psychomotor retardation if you have this. So people move more slowly, and they even may talk more slowly, and it seems to be effortful to get to do things, and so physically moving slower. Fatigue or loss of energy, so again, which is really, I think, key to what depression is. It's really about low energy and low motivation. And fatigue, not surprising that one of those symptoms could be insomnia. Feelings of worthlessness or excessive or inappropriate guilt. Excuse me. And just a quibble I have here with the DSM, because from a kind of a CBT perspective, that probably should be thoughts of worthlessness or excessive inappropriate guilt. That you think you're worthless, you don't feel you're worthless. And when you think you're worthless, you feel sad. But that's just a quibble of mine. But thoughts or feelings of worthlessness or excessive inappropriate guilt. So everything's my fault. Right? You see things that you shouldn't be responsible for. You're taking responsibility for that. Nobody in my family's happy. It's all my fault. I'm not doing what I should be doing. Or worthless. I just can't do anything right. I'm no good. Nobody loves me because I'm not worth loving. That kind of thing. A diminished ability to think or concentrate, which may be associated with indecisiveness. So again, just can't think clearly. When you can't think clearly, it makes it hard to make decisions. And then the last one of this list, recurrent thoughts of death, recurrent suicidal ideation, suicide attempt, or specific plan for suicide. So what's the difference between recurrent thoughts of death and recurrent suicidal ideation? Suicidal ideation is more specific. Thoughts of death are, gee, I wonder what death is like. I wonder what it's like to not be here. I'm thinking about people that are dead and kind of ruminating on death in general. That's thoughts of death. Recurrent suicidal ideation is thinking about taking your own life, causing your own death. Okay. So one way to think about these symptoms is to group them into 3 categories: cognitive, somatic or vegetative, and behavioral. Cognitive being those things about thinking about suicide, difficulty concentrating, feelings of worthlessness. Somatic or vegetative are those kind of physical symptoms like the weight change, appetite, difficulty sleeping, and then the behavioral symptoms where you have diminished interest or pleasure in activities. That's the one. But some argue that the somatic symptoms of depression are most diagnostic of a major depressive episode. Right? The idea that a lot of us will experience some difficulty concentrating, indecisiveness. You may even feel depressed, kind of have that mood symptom, but it's when there's that weight change or appetite change and you can't sleep and have psychomotor retardation. Those things might really help us distinguish between, okay, is this depression or is this someone who's just pretty sad because of things that are going on in their life? And it can be a tough thing to discern, which we'll talk about in a bit. Other symptoms, associated features of a depressive episode that aren't necessarily diagnostic but frequently co-occur include tearfulness, right? Brooding or rumination. This is where somebody sits and just thinks, usually about negative things over and over again, kind of going around in circles in their mind. Worry, right? Which, not surprisingly, we see some overlap with generalized anxiety disorder, because people who are experiencing a depressive episode often tend to ruminate about negative things and worry. Right? So it looks very much like somebody with generalized anxiety disorder. Somatic complaints, kind of headaches, joint pain, those types of things. Okay, one other thing to note, again, to meet criteria for this mood episode, which we don't diagnose somebody with an episode, we diagnose them with a disorder, but we have to know what the episode is, how it's defined, to figure out, okay, if you meet the definition of the episode, then that tells us which mood disorder you make criteria for. Right? Anyway, this mood episode, you have to have the symptoms during this 2-week period. And the length of a mood episode varies across individuals, and even within an individual. If they have recurrent mood episodes, they may not always be the same amount of time. Typically, they're close. People have kind of a set, a typical pattern. Oh, I get down for about this long. But it may vary. But it definitely varies across individuals. But the average length of a mood episode for a depressive episode is about 4 months. So again, only has to be 2 weeks, but typically is a good bit longer than that. So quite a while, 4 months. Think about how long that is of feeling this way, of having 5 of these symptoms or more. Quite often more. Okay, so that's criterion A. Criterion A of a depressive episode is 5 of these symptoms. And then you also say it's not a mixed episode, which means that you don't also, at that same period of time, have some manic symptoms, which some people do. They have kind of, I can't sleep, I can't think, I'm not eating, but I am talking a mile a minute a day later or 2 days later. Right? Might be a mixed episode, which we'll talk about what that looks like in a minute. So it's not that, it's purely depressive symptoms. The symptoms cause clinically significant distress or impairment, which again, up to you as the clinician to determine if the amount of distress or impairment is significant. The symptoms are not directly attributable or due to a substance or general medical condition, which doesn't mean it's not a problem, it just means it's not a major depressive episode, it's substance-induced whatever, or due to a general medical condition. And it's also not bereavement, right? And again, bereavement isn't a disorder per se, but it is in the DSM, and it talks about what bereavement looks like. And what it comes down to for depression, and when trying to rule out if it's bereavement or not, basically, if you've lost a loved one or something important and experienced some of these symptoms, the DSM gives you 2 months to have those symptoms. If the symptoms persist after 2 months, then you begin to consider that it might not just be bereavement and that the loss may have triggered a major depressive episode. But this kind of gives you that amount of time, 2 months, to have difficulty sleeping, not eating, feeling sad, don't want to do things. You gotta put that long. If it goes beyond that, they say, okay, well, this might really be a major depressive episode. Or even if it's less than 2 months, if the symptoms are severe. So if there's lots of impairment, so you lose someone and you're not able to go to work at all or go out, leave the house for like a month. So we haven't reached 2 months yet, but it's pretty severe impairment. Looking at the possibility that it is a major depressive episode. Or if you have psychotic symptoms, if there's suicidality, that's not something that's super common among the bereaved. Thoughts of suicide, yeah, kind of suicidal ideation where they kind of keep coming back to it and really considering it, not so much. That is more indicative of a major depressive episode. And then also, if that psychomotor retardation is present, that's something you don't see as much with an uncomplicated bereavement. Okay. And how did they decide that you have 2 months to have these symptoms before it changes? They took a vote. Okay. Manic episode. This is a distinct period of abnormally or persistently elevated, expansive, or irritable mood lasting at least 1 week or shorter if hospitalized. Okay. Abnormally elevated, so you're feeling better than you should. So something good happens in your life, you may feel really good. And you may feel really good for a week. I'm in a good mood. But that may be a normally elevated or expansive mood, right? Or if you're just having a really crappy week and people are really ticking you off and you're feeling kind of irritable, you may have a normally irritable mood for a week. But most people, their mood shifts, from throughout the day and from day to day. This is where it's kind of persistently elevated. So being really irritable and something nice happens, not even being able to, oh yeah, well at least that's going good. Sticking with the irritability, or with the elevated expansive and see, oh, something bad happens, yeah, but I don't care, everything's great. Kind of bulletproof from any kind of negative events. Right? So that would be an abnormally elevated or expansive mood if it's not responsive to kind of bad things happening. Again, so lasts for at least a week, as opposed to a major depressive episode, which was 2 weeks. But we have this caveat here: shorter if hospitalized. Now think about why that would be. Well, what happens if you become manic and you get hospitalized because maybe you've hurt yourself or people are concerned about you? What do? They give you meds, and not things like lithium that take a while. They get you stuff to bring you right down, to make you not manic. Right? We can make you not manic pretty quickly. You can't take those drugs on a regular basis. You can say, oh, I'll just wait till I'm manic and then I'll swallow some Thorazine. Not a good long-term plan. But in hospitals, they often do that to get somebody to where they can think more clearly and make decisions for themselves about their medical care and all those types of things. So if somebody gets hospitalized, they're going to be medicated. And so if they've only had the symptoms for 4 days, we say, well, the assumption is they still would have had the symptoms if they hadn't been hospitalized and medicated. Okay. So depression, you had to have 5 or more symptoms. For mania, it's 3 or more. 4 if the mood is irritable instead of elevated or expansive. So again, that elevated, expansive, feeling really good and great about things seems to be more indicative of a manic episode. So if your mood is irritable, like, whoa, irritability, well, that also occurs in depression for young people, so we got to really make sure it's mania, not something else. So we just require more symptoms of mania to go along with it if the primary mood symptom is irritability instead of that feeling really good. Okay. Inflated self-esteem or grandiosity. So feeling you're the best ever, right? And good about yourself, and that you have done great things, can do great things, that type of thing. A decreased need for sleep, and this is interesting because it's not just it's not like insomnia where I can't sleep, I'm so tired. This is where people really don't feel they need sleep, right? So it may take 3 hours, 4 hours, or it may go 24 hours, without sleeping at all, 48 hours, whatever it is. And not feeling sluggish and tired, still feeling good, feeling fresh, right? So again, not just insomnia, a decreased need for sleep. Extra talkative or pressured speech. So again, we're talking about something that's a change from before. Somebody who's generally a talkative person. If you see them and they're talking, like, "Ooh, you look manic." Well, that's just the way they are. They're more talkative than usual, or they have pressured speech. And pressured speech is whenever somebody's talking and it seems like they're trying to get everything out and they just can't get the words out quickly enough because they want to say some things, and you don't understand. They have to let you know, right? So that's pressured speech, almost as if there's pressure in the back of their head trying to push the words out and they can't get it out quickly enough. Flight of ideas or racing thoughts. So flight of ideas is whenever somebody is talking about one thing and they suddenly go off on another tangent, and so there's not this kind of direct linear line. Almost again as if they're having so many ideas and thoughts coming into their head that they can't select one train to stay on. They've got to get it all out. Right? Racing thoughts, which obviously we can't see, so that's something that they have to report to us, that it feels like lots of ideas are coming through. So typically you diagnose that criteria based on their pattern of speech. Okay. An increased sense of distractibility. So looking a little bit ADHD here during a manic episode. So generally they can sit and focus on something, but when they're manic, any little thing will distract their attention from from your conversation with them, from trying to do one thing, whatever it is. They can get off track more easily. Increase in goal-directed activity. Now you have this symptom. This one is one that people often like to have. Right? This is where you get stuff done. right? So maybe you're working on this term paper and you're slugging through, and then something happens and you become manic, and then you write 50 pages, right? And you paint your house, and you mop all the floors in your house, and you clean all the windows, and you buy all your Christmas presents online, and you do all this stuff. And it's not kind of aimless activity. It's increased goal-directed activity, where there's something that needs to get done. Well, needs to. Something that could get done, where there's some goal, and you work toward that more so than you would before. So again, kind of this high energy. And sometimes the high energy is directed towards getting stuff done. Okay, one that may not be so good for you. Excessive involvement in pleasurable activities that are dangerous. So this is kind of going out and having indiscriminate sex with multiple partners, shopping sprees, gambling binges, those types of things. So almost like the inhibition is gone. It's like, I feel so good, I want to keep feeling good, and there's no thinking about consequences. Okay, so 3 or more of those. 4 if the mood is primarily irritable. And then again, it's not a mixed episode. So you don't also have some depressive symptoms mixed in this period of time. If you do, we're talking about a mixed episode. The symptoms cause impairment, require hospitalization, or include psychotic features. So if you have kind of an increased inflated self-esteem, you feel really good about yourself, a bit more talkative, and you're getting a lot of stuff done, but it doesn't cause you any problems. You don't have to go to the hospital because you didn't do anything dangerous, and you're not having any hallucinations or delusions, then you're just really lucky to have this period of really good mood, and we don't consider it a manic episode. So again, this is the DSM's attempt not to over-pathologize, and only to say, okay, it's pathology when there's some problem. Okay. So if you're able to be manic without it causing problems, it's not technically manic. And then again, as with other things, the symptoms are not due to a general medical condition or a substance. Obviously, tox screen is often something people will do when they go into, if they present to the ER looking manic, and they look, gee, let's make sure that they're not on, and usually the assumption is that they're on, cocaine or amphetamines or something like that, because it often looks similar to those types of intoxication. Mania does in some people. Okay. So now we keep saying a major depressive episode, a manic episode, are not a mixed episode. So what is a mixed episode? Well, this is when their criteria met for a manic episode and a major depressive episode for 1 week. So you have this 1 week period of time where you have those 5 symptoms of a depressive episode and 3 symptoms of a manic episode in the same time period, right? So it could be this kind of quick cycling where during the day you wake up and feeling really kind of depressed and lethargic and tearful, and then later in the night getting a bit more mood coming up, and then getting manic and staying up all night getting stuff done, and then the next day coming down. So it could be mood changes in the day, or it could be the first part of the week, 2 or 3 days depressed, and then flipping over to manic. Either one of those, but you have all those symptoms in some combination in 1 week period. Okay. The symptoms cause distress or impairment. We don't want to over-pathologize. And like everything else, we say the symptoms are not due to a general medical condition or a substance. Okay. So we've talked about a major depressive episode, a manic episode, and a mixed episode. What's mixed just meaning the combination of the two. And then we'll talk about our hypomanic episodes. Okay. Hypomanic episode is a distinct period of persistently elevated, expansive, or irritable mood for 4 days that is different from typical non-depressed mood. Okay. Hopefully that sounds familiar, because it's very similar to the language used to define a manic episode, right? Because it really is. It's just a little less. Okay. So at least 3 of the symptoms from criteria B for a manic episode are present. So all the ones we talked about before, inflated sense of self-esteem, grandiosity, decreased need for sleep, pressured speech, flight of ideas, racing thoughts, yada yada yada. 3 of those things. But the episode is an uncharacteristic and unequivocal change in functioning. So this isn't somebody who's just really upbeat. And there are people that are like that. They seem to be always hypomanic. Some kindergarten teachers appear that way, at least in public. Always very cheerful, always high energy, just go, 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 go. So if they're always like that, then it's not an episode, right? Episode is a distinct period of time that's different from typical. And this is thrown in with hypomanic because, manic episode in regular normal mood, there's a pretty good gap, and you can tell the difference. Hypomanic is between the two, so it's getting closer to normal mood. So now we have to put in this kind of criterion saying, be sure it is a mood episode. It's not just somebody who's feeling good. Along those lines, the change in mood and functioning is observable. So it's not just subjective, where they feel as if maybe I'm feeling a little hypomanic. Other people have to notice it too. You have to be able to tell, or somebody in their life has to tell, yeah, it is a different thing. They are kind of here, but then they went up. But the symptoms are not severe enough to cause impairment or hospitalization. So again, it's mania, but without the impairment. And symptoms are still not due to a general medical condition or a substance. Okay. So, if you're feeling pretty good, but it doesn't cause impairment, might be hypomania. But has to be, you're feeling pretty good, has to be observable to others. And again, it's for a period of 4 days, which again is also, I should say, shorter than a manic episode, right? Manic is a week. Hypomania only requires 4 days. But it's not just 1 day I felt really good or 2 days. It has to be this period of time, at least 4 days of feeling good, kind of consistently throughout that those 4 days. And I felt good in the morning, then I was kind of down, then I came back up, then I was down. But yeah, overall I felt pretty good these 4 days. No, it's persistently across those 4 days or longer, feeling pretty good, but not so good that you're going to go and do dangerous stuff or need hospitalization. Then it would be a hypomanic episode. And again, hypomanic episode, if you have that with major depressive at some point in the time, then we're talking about bipolar 2. It's important when trying to figure out somebody's diagnosis, if they have a history of major depressive disorder and they come in and they're feeling pretty good, you have to distinguish between, okay, is there feeling pretty good hypomania, or is it simply the absence of depression, right? So if they're having inter-episode recovery where they're coming out of a major depressive episode and returning to a normal mood, euthymic mood, they may think, well, I think I might be hypomanic, I'm feeling good, right? Depending on their level of awareness, they may mistake normal mood for hypomania. And so you have to be careful here to, again, look for those things where it's uncharacteristic of them, so across their life, this change, and that it is observable change. That, again, that it's going beyond normal mood. So they came up and then kept going. Okay, about one other thing, which kind of stat stuff. About 15% of people who meet criteria for a hypomanic episode go on to eventually develop a manic episode. Okay, so not everybody. So hypomanic episodes are relatively common, at least relative to manic episodes. So people have them without going on to have mania. People also have them without having major depressive episodes. So you might have a hypomanic episode and not have a depressive episode, not have a manic episode. And if you just have a hypomanic episode, even if you have them recurrently, not necessarily a disorder. Okay. Let's come back to the disorders. Major depressive disorder. One or more major depressive episodes. So currently or history, and you may have more. If you have more, we add a specifier talking about you have recurrent depression. Your major depressive episode is not better accounted for by schizoaffective disorder and is not superimposed on a psychotic disorder. So a schizoaffective disorder is where you have prominent mood symptoms and prominent symptoms of psychosis, but the psychotic symptoms are still present when the mood symptoms are not. Okay, so even when you're not depressed, still have some psychotic symptoms. Okay, then we're looking at schizoaffective, where you have the kind of combination of mood stuff and psychosis. But you might have psychotic symptoms with a mood episode, right? So if you only have psychotic symptoms when you're depressed or when you're manic, then it's not schizoaffective. It's major depressive disorder with psychotic features, or bipolar disorder with psychotic features. Okay. But so if there's psychotic stuff, we have to say, well, is it just when they're in depressed mood, or is it other times? If it's other times, then it's probably not this mood disorder. It's either schizoaffective, or again, if the symptoms are simply superimposed on a psychotic disorder, they're just it's where the depression is judged to be part of the psychosis, right? Where I think aliens stole my heart, and therefore I'm sad. Okay, well then it's not depression. The depression is part of the psychosis. Okay. There's no history of a manic, mixed, or hypomanic episode. As soon as you have one of those, your diagnosis changes. You have these mood episode specifiers. Excuse me. About a couple things. One could be the severity of the current mood episode. Mild, moderate, or severe. And then severe, it can be severe with psychotic features or severe without psychotic features. Okay. You're not going to have mild or moderate with psychotic features. Psychotic features automatically bumps it up to severe. A chronicity specifier. So you can add the specifier of chronic, so major depressive disorder, chronic, if the major depressive episode has lasted for 2 years. So again, not having some symptoms, mood episode comes and it goes, so not having depression for 2 years, but having a major depressive episode, meaning full criteria, so more days than not, every day, just about, for 2 years having these symptoms. That's a chronic major depressive episode. So it's again, and the chronic applies to the episode, not the disorder. So major depressive disorder, most recent episode, depressed, chronic. Sometimes if there are certain features, you may specify these. There are different subtypes of depression, and there's some thought that different subtypes of depression respond differently to different treatments, and may also have different courses, and that's why we separate them out. Catatonic depression or catatonic mood episode is when it can occur in any mood episode except for hypomanic. So you can be catatonic with a manic episode, or depressive episode, and that's when you have two symptoms, including things like motoric immobility, as evidenced by catalepsy or stupor, where you can't move, or you have the kind of waxy flexibility where people can position you, and they hold your arm up and they let go and your arm stays where they left it. That's really kind of a severe depression usually. May also have excessive motor activity that's apparently purposeless. Right. So again, with mania, you may have excessive motor activity, but it's all geared toward doing something. With catatonia, it's just kind of moving, and not doing anything. Extreme negativism, which is somebody seems to have no motivation to do anything, kind of resistant to all instructions. You try to move them, and they won't move, and they won't tell you, I don't want to go. They just won't do it, and they just won't do things. Mutism, or not speaking, peculiarities of voluntary movement, So posturing, stereotype movements, prominent mannerisms, echolalia or echopraxia. So echolalia, the repeating of the words others say. Somebody says, so if you come in and say, "Hey, how you doing?" and they go, "Doing, doing, doing," just kind of parroting that. Echopraxia, the same thing, but with motor movements. Come in and shake their hand, and they hold it out and shake it. You let go, and they keep shaking. Right. So catatonic depressive episode, or a catatonic manic episode. Further on the scale of severity. So not going to be using probably some talk therapy as the first line of defense there. A melancholic depressive episode doesn't apply to manic, just applies to depressive episodes, but can be with either major depressive disorder or bipolar disorder. Key features of melancholia: loss of pleasure or lack of reactivity to pleasurable stimuli. So again, this is where it's not the sadness, but just no fun, no joy. You go watch Will Ferrell movie, one of the good ones, and you don't laugh at all. Right? So you have that, and three other things like depression's worse in the morning. They wake up early. Psychomotor symptom, either retardation or agitation, is common. Loss of appetite, weight loss, and excessive guilt. Okay. And this idea of melancholic depressive episode really has a long history. Former diagnosis a long time ago was melancholia, which is thought to be kind of separate from other types of depression. Atypical depression applies to the 2 weeks of major depressive disorder. You can also have atypical symptoms of depression in dysthymia. This is where you have mood reactivity, so you will laugh at Will Ferrell movies. And so that's atypical for depression. And then you have two other symptoms. So weight gain or increase in appetite. Again, I told you typically it's the loss. But if you have that, or hypersomnia, where you're sleeping all the time, leaden paralysis, a long pattern of interpersonal rejections and sensitivity. That would be an atypical depressive episode, or atypical depression. Okay, the last one for features would be postpartum onset. So when we talk about postpartum depression isn't a separate diagnosis, right? You won't find that in the DSM as a whole separate thing. It's just major depressive disorder, postpartum onset. So you just add that specifier to kind of let people know the mood episode started after they give birth, and that can be for a depressive episode or a manic episode. Doesn't apply for hypomanic. You can also have, just kind of a side note, for a brief psychotic disorder, it can also have a postpartum onset. And this is, how far away from partum, from giving birth, can it be? 4 weeks. So the onset of symptoms is within 4 weeks postpartum, within 4 weeks of having a baby, developing a pattern of symptoms of a mood episode. Okay, so depending on what prominent features are there, if they kind of look like one of the different subtypes of depression, you may add that specifier. And then you also, if they're in remission, so you've been seeing somebody a while, or they were seeing somebody else and they're coming in now and they're not currently having a mood episode, then they're in remission. Again, with the idea, it's not necessarily that, oh, I'm getting better. It's just, if you're not currently experiencing a mood episode, then you're said to be in remission of some type, either full remission or partial remission. So if full criteria are not currently met for a mood episode, in full remission requires 2 months of not meeting criteria. So really, the remission is not about remission from major depressive disorder. It's about remission from the mood episode. If you have recurrent mood episodes, there are other specifiers that can be added to kind of give more information on the diagnosis. With or without inter-episode recovery, depending on which is present. And this is just whether or not there's full remission between mood episodes. So if somebody has a mood episode, and then they go a full 2 months without meeting criteria for a mood episode, then they have inter-episode recovery. If they don't, so if they're really depressed, things get better, no longer meet criteria for a couple of weeks or a month, but then they get depressed again, then they do not have inter-episode recovery. It'd be major depressive disorder without inter-episode recovery. And then with seasonal pattern, you might also tack on. This is if the onset of mood episodes seem to be related to time of year, and not just because of life events correlated with time of year. So, somebody they always get depressed around Christmas because that's when their mom died. Well, that's not. We don't use the seasonal pattern specifier for that. This is when it really seems to be related to changes in seasonal patterns, amount of light they're exposed to, those types of things, circadian rhythms. So, seasonal affective disorder, that's what this is. You add that specifier to a mood disorder, and that's seasonal affective disorder. But we don't call it that, we call it major depressive disorder with a seasonal pattern. Okay, bipolar 1. So, currently or history of manic or mixed episode, maybe multiple manic episodes, maybe manic and mixed, multiple mixed, whatever. So one or both of those. Can't have a bunch of them. Can't have just one. You may have a current or previous major depressive or hypomanic episodes, but not required for bipolar 1. Typically do, but not required. Excuse me. And the mood episodes are not better accounted for by schizoaffective disorder and is not superimposed on a psychotic disorder. So same thing we talked about before, where if you have a lot of mood symptoms and some psychotic symptoms, we're looking at maybe a schizoaffective disorder or a psychotic disorder that has some, manic, in this case, features. But if you only have psychotic symptoms when you're manic or when you're depressed, then it's a mood disorder with psychotic features. So you have to figure out if there's psychotic features present, what's the better explanation? Does psychosis seem to be secondary to the mood disorder, or is the mood secondary to psychosis? If it's secondary to psychosis, then we're looking at a psychotic disorder, schizophrenia perhaps, or schizoaffective, where you have even maybe a lot of mood symptoms, but you have psychotic symptoms without any mood symptoms. The mood episode specifiers. Same types of things, largely that we see with major depressive episodes. The severity, mild, moderate, or severe, with or without psychotic features. For chronic, this is sorry. Same type of thing you see with major depressive episode. And then the features, there's less stuff to apply to. Let me back up one sec. The chronicity, it's the same stuff for depression because it's only if you have a major depressive episode with your bipolar 1. So you don't really see chronic manic. People aren't manic for 2 years, right? That's usually a time-limited event. It seems like you can only be manic for so long. You can be really depressed for a really long time, but it seems like, for whatever reason, people aren't able to stay manic chronically. But you could have, if the most recent episode is a major depressive episode, then you might have the chronicity specifier. Features. Okay, if it's a major depressive episode, some stuff talked before. For manic, you can apply the catatonic specifier or the postpartum onset one. Remission, same type of thing before, but again, more likely to have remission with manic episodes than depressive episodes. Full inter-episode recovery. The core specifiers, if you have recurrent mood episodes, again, same stuff with inter-episode recovery. The seasonal pattern, it really only applies to a major depressive episode. We don't see people having, at least diagnosable right now, because the research says that people don't seem to get manic in patterns that are consistent with the seasons. That seems to be more of a depression thing. But then one thing that occurs with bipolar 1, because it relates to mania and not to depressive episodes, is rapid cycling. So that's only for bipolar disorders. And this is when people think, oh, rapid cycling, you have lots of mood disorders, or lots of mood episodes. So that must mean like you're manic today, depressed the next day, manic and depressed, rapid cycling, right? Not that rapid, right? The rapid cycling specifier for bipolar disorder talks about having a certain number of mood episodes over a year. So not talking about within a week or a month, talking about over 12 months. And going from manic to depressed to maybe hypomanic to whatever, any kind of changes from, okay, it's clearly this type of mood episode to this one. And you could have normal mood in between. Don't have to, but you could. But it's 4 mood episodes in 12 months. That's rapid cycling. Okay. So again, rapid isn't this week, next week, this week, next week. Right? It's for these 3 months, or for this 2-week or 3-week period, and then normal mood for a while. A few months later, depressed for 2 months, and then maybe a few weeks later, hypomanic, and then a month later, fully manic. Okay, that's rapid cycling. It's not as rapid as maybe the name implies. It doesn't have to be. It could be. People could have more episodes than that, but you only have to have 4 mood episodes in a 12-month period to be considered rapid cycling. And let's tell you a little bit about how the typical experience of somebody with bipolar is. Okay, bipolar 2, a current or previous major depressive episode. Again, so bipolar 1, you can have a depressive episode or not, doesn't matter. Bipolar 2, you have to have it, right? Because hypomania isn't enough by itself, so you have to have some kind of full-blown mood episode, which can't be mania, because that's bipolar 1. So you have to have a major depressive episode, currently or history, and then current or history of a hypomanic episode, right? So it's not just depression, it's something different. But you've never had a manic episode or a mixed episode. And again, the mood episodes are not been accounted for by schizoaffective disorder, and it's not superimposed on a psychotic disorder, so things before. The symptoms cause distress or impairment, and the specifiers are the same as what we just talked about for the other. Dysthymic disorder. Here's one we haven't talked much about yet. This is where you have chronically depressed mood for 2 years or longer. Some people talk about it being kind of a lifetime thing. It's just always been this way, always depressed, always down. This is kind of the Eeyore disorder. Think about the Eeyores, always sad, always mopey, always low energy. So while depressed during this period of time of 2 years, at least 2 symptoms. Again, this is most of the time. So it's not every day, but it's more days than not. So poor appetite or overeating, so some sort of appetite disturbance, insomnia or hypersomnia, low energy or fatigue. So again, notice how somebody's saying, oh, this or this, this or this, but it's not low energy or fatigue or lots of energy. No, it's low energy is kind of a key feature of dysthymia and depression, right? That's what it's about. It's about being low and not being motivated to do stuff. Okay. Low self-esteem, as opposed to with mania we see inflated self-esteem. Right? Poor concentration or difficulty making decisions, or possibly feelings of hopelessness. Okay, so things will never get better, things will never change. Life sucks, it will always suck. So during this 2-year period of a mood disturbance, there was never a 2-month period where symptoms were absent. So it's not like, oh, you had a really rough year, things really sucked, you had this all the time, and then maybe you met someone and things were going good, you felt really good about it, and you're happy, you're laughing, all those symptoms went away for a few months. And maybe that person broke up with you, and you went back to being sad. Well, then, sorry, you don't meet criteria for dysthymic disorder unless you can stay sad for another 2 years. So it has to be this continuous period of 2 years where more days than not you're having the symptoms, and you don't have this kind of window of sunshine that's 2 months wide. Also, during the first 2 years of the disturbance, there's not a major depressive episode. Because again, if you have a major depressive episode and then are kind of sad afterward, we think, well, that's probably just major depressive disorder, generally. But you could have 2 years of being depressed, maybe 10 years of being depressed, and then develop a full-blown major depressive episode after that time. So you've been a kind of a sad person always, and then you have this mood episode. If that's the case, your diagnosis doesn't convert from dysthymic disorder to major depressive disorder. You add them. So it's dysthymic disorder and major depressive disorder. And it's sometimes referred to as double depression, which many people feel is more difficult to treat, responds less well to treatment than depression by itself. So you can have a major depressive episode, but you have to have had at least 2 years of this kind of depressed mood before your first mood episode. No history of manic, mixed, or hypomanic episode, and it's not cyclothymic disorder, which we'll talk about in a little bit. So this is about being kind of always depressed and never having that, having maybe some normal mood for a week, 2 weeks at a time, maybe even a month, but not getting that above normal mood where you're getting hypomanic or manic. It's not exclusive to a psychotic disorder. So somebody who has a psychotic disorder, and whenever their psychotic symptoms are treated and under control, if this kind of depression goes away, then it's not dysthymic disorder. That was just a feature of their psychotic disorder. Because people who have psychotic disorders often do appear kind of chronically depressed because it's difficult going through life with experiencing psychosis. Right? Also not due to a substance or general medical condition. Go rule out stuff. And the symptoms cause distress or impairment. Again, we want to set this apart from people who are just kind of sad people. Well, it's sad enough that it's bothering you or getting in the way of your life. You can tack on specifiers related to two things. One, the onset, either early or late. Early onset is before age 21 years. Late onset is after that. With the idea being that the outcome may be different for early onset versus late onset. And then you can also have with atypical features, just like we talked about before, with major depressive disorder. With a major depressive episode, if you have that mood reactivity where you can laugh at stuff and you are sleeping more and eating more, those types of things. So if you're overeating and being hypersomnic, that would be dysthymic disorder with atypical features. Okay. So again, it's kind of like depression stretched out over a long period of time. The last bullet on there should say symptoms cause distress or impairment. Okay. So we've talked about major depressive disorder, bipolar 1, bipolar 2, dysthymic disorder, cyclothymic disorder. Okay, so these are all the kind of major mood disorders in the DSM. And now I kind of want to go back and talk about normal variation in mood, getting sad, getting happy, and how you differentiate between that and a clinical mood disturbance, a clinically significant mood disturbance. Sadness or happiness without the other symptoms is not clinical depression or mania, right? So if you're feeling sad, even if you're feeling very sad, like something bad happened, or you watched a sad movie, whatever, and you're feeling very, very intensely sad, that's sadness, and that's part of life, right? And we gotta be careful not to over-pathologize sadness. Right? If you're sad but don't have the loss of appetite and can't sleep, excessive guilt, those things. If you don't have 5 symptoms of depression, then it's not depression. You may be depressed in kind of the colloquial, common language sense of, yeah, you're sad and that sucks, but it's not pathology, right? And it's okay to be sad, and you don't necessarily need intervention or medication to keep you from being sad. Same thing with mania. There may be periods where you feel really good about yourself and productive and happy, and again, that's normal and okay. but it's probably not going to cause impairment, and so we're not going to pathologize it and call it mania. So, what if you're sad and you have so many symptoms, or you have maybe 5 symptoms, but they're not real severe? Well, I'm not real hungry. I have a bit of a decrease in appetite. Okay, well, where do you draw the line? So for each symptom, how much difficulty sleeping do you have to call it insomnia? How much loss of appetite do you have to call it loss of appetite? If I feel a little guilty for something I did, how much guilt do I have to feel to say, oh yeah, I have excessive guilt? Well, in reality, there are no clear lines kind of demarcating these things. So the difference between sadness and clinical depression, even though with enough experience, you may be able to fairly reliably tell the difference, depending on the clients you see and your own skill level. You may not ever be able to explain to people how you tell the difference. Right? There's not a line you can draw. So this much, this many, this long, this amount of time. Oh, this blood test, whatever. We don't have that. There's not a clear line. There's some grays, right? And two people that look pretty similar in their level of sadness and their symptoms, one of them may be experiencing a clinical mood disturbance and the other not. So how do you figure out which side of the line people may be on, this kind of line that doesn't exist? Well, there are some indicators of the transition from normal sadness and depression and normal feeling good to mania. And again, it's not like, oh, if you have these, it's this way, and if you don't, it's not. These are just things you should be thinking about when trying to make the decision. The mood, whether or not it's pervasive across situations and over time. Right? Clinical mood disturbance typically is pervasive and stable. So if you're feeling sad but not experiencing a major depressive episode, your friends might be able to cheer you up. Right? And you can kind of shake it off for a while. If so, then it's less likely that it's a major depressive episode. Right? Or if you're feeling really good and then again something shitty happens and you start to feel down, you probably weren't manic. Okay? As it's across situations over time. So, and the time thing is obviously built into the criteria. 2 weeks for a major depressive episode, 1 week for a manic episode. But again, typically for a major depressive episode, it's longer than that. We're looking at 4 months. So it's kind of the stable thing. It's a change, right? So it's not just this kind of gradual thing. The change in mood can come out of nowhere or be disproportionate to circumstances. So if things are going fairly well in your life and you're feeling really sad, okay, well then we're thinking more likely that it's a depressive episode than if things are really going poorly. Your dog just died and you didn't get a promotion at work, and there's these several negative events. Then you may be experiencing a major depressive episode, but it's going to be harder to tell, right? Because you've got some circumstances in your life that suggest you should be feeling crappy, right? So if you should be feeling good and you're not, then now we're thinking, okay, this might be a mood disturbance. Same thing with mania. If there's kind of bad crap going on, and you're like, hey, everything's great. Okay, you might be manic right now. If your mood doesn't match your circumstances, if it's out of proportion. Again, or if the change comes out of nowhere. If you have the cognitive, somatic, or behavioral symptoms that we've talked about in the DSM, right? So if you don't have those patterns of symptoms, excessive thoughts of guilt, difficulty sleeping, kind of withdrawal, or the racing thoughts, engaging in unsafe behaviors. If you don't have that stuff too, then maybe you're talking about, well, you are feeling really good or you're feeling really bad. But if you have these other symptoms, it's kind of symptom clusters, then we're thinking, okay, it looks like this syndrome, which we know as a clinical mood disturbance. And then the last one on here I'll talk about is people often report a subjective experience of a different quality of the mood change, right? So, like with depression, I've been sad before, but this is different, right? It just feels different. And they want us to say, oh, I've been sad before, but I never, didn't sleep this much or whatever. They may not talk about their symptoms. It just may be this kind of subjective thing. It feels different. right? Which again, you're going to be relying on your clients to tell you about this, their subjective experiences, not something you can observe directly. Okay, the experience of mood disorders are about things like course and prevalence. The onset for major depressive disorder, average age of onset is in mid-20s. Same for the bipolar disorders. But dysthymia, we're looking at more commonly onset in childhood or adolescence. And the cyclothymia a little later, so adolescence to early adulthood. So earliest is dysthymia, and then cyclothymia, and then after that, your major depressive disorders and bipolar disorders in terms of when we see the first symptoms. So dysthymia looking very much kind of like a characterological thing. If you have this kind of childhood onset, always been that way, then it may be almost like a personality disorder. It's just kind of how they are. They see the world negatively, and it's going to be kind of a stable thing. In terms of prevalence, rates vary depending on what surveys you look at. Major depressive disorder as high as 17% of the population in the USA, lifetime prevalence. Bipolar 1, nowhere near as common, 1.6%, and bipolar 2, 0.5%. So bipolar 1 much more common than bipolar 2. So if you're going to have the kind of mood changes from depression to mania and hypomania, more likely to meet that full criteria for mania than just having hypomania. Dysthymia 6% and cyclothymia 1%. So in general, people likely to be more kind of experiencing depressed mood than good mood related to pathology. In terms of gender ratios, major depressive disorder is twice as common among female adolescents or adults as male adolescents or adults. But if you look at kids in the child population, it's about the same, boys and girls. Bipolar 1, you have an equal gender ratio. Bipolar 2, slightly more women than men. Dysthymia, 3 times as common in women than men, but again in kids it's the same. And in cyclothymia, it's about the same. So what we see here is whenever we have things with more mania, cyclothymia and bipolar 1, we see kind of equal amounts of equal gender ratios. But factor in depression, and it looks like more women. But again, more women than men, but not necessarily girls than boys. Which may lead you to think about, well, why would that be? Why do we see this kind of burgeoning difference between experiences between male and female individuals as they get older? Right? A couple of hypotheses, right? Could have to do with socialization, how you're taught to be, how you're taught to deal with your emotions. May also have to do with biological maturation, right? With the emergence of secondary sexual characteristics, humans become more different from each other post-puberty than they were pre-puberty. Okay. In terms of comorbidity, mood disorders rarely occur in isolation. Major depressive disorder is most often comorbid with an anxiety disorder, like generalized anxiety disorder. May also be comorbid with substance use disorders. Again, sometimes it's a matter of self-medicating. Sometimes it's a matter of people that become dependent on substances. Sometimes the dependence on the substance leads to some changes in their life in terms of isolation, and that may put them at greater risk for being depressed. Bipolar disorders, again, rarely occur alone, most often comorbid with anxiety disorders. Dysthymia, comorbidity with major depressive disorder, double depression, or anxiety disorders, and then cyclothymia, substance use, and bipolar disorders. In terms of mortality, the major depressive disorder, common feature is suicidal ideation. But not everybody who has a major depressive episode or a major depressive disorder commits suicide. but it is a significant number. 10 to 15% of people in clinics diagnosed with major depressive disorder complete a suicide attempt. So more than that attempt, and it's hard to get good numbers on number of attempters who don't complete because they often don't report it if the attempt isn't severe enough to warrant medical attention. But 10 to 15% complete suicide. So there is a significant risk there. And mood disorders in general may also be associated with acts of violence against other people. Again, it's not the norm among mood disorders, but it is a potential associated feature. Right? When your mood isn't typical, especially if it features irritability, there's a greater risk of acting out and hurting others. Okay, in terms of etiology, look at a couple things. Look at biological factors first. Genetics, as with everything is genetic. Right? But in terms of how much we understand of the role of genetics in these disorders, depends on what we're talking about. For the heritability estimates, which it has to do with, again, the amount of variability in a population that can be explained in a mood disorder that can be explained by the variability in their genetics. Right? So it's not about how much of this individual's mood disorder is caused by genes. It's how much is the variability in these people in terms of their expression of a mood disorder, how much of that is correlated with how variable they are, how different they are genetically from each other. That's what heritability estimates are. Anyway, heritability estimates are somewhat higher for bipolar disorder than major depressive disorder. But family members of someone with a bipolar disorder are at a generally increased risk for mood disorders and not bipolar disorder per se. Right? So if someone in your family has a bipolar disorder, then you may be at a greater risk for developing a mood disorder. So bipolar, major depressive, cyclothymia, dysthymia in general, but not necessarily specifically for bipolar disorder. Which is interesting. So it seems to be something related to mood, but not specifically mania, this kind of genetic contribution. There's also some really interesting evidence related to gene-environment interactions, right? About how kind of genetic vulnerabilities may interact with environmental inputs. Caspi et al. Did a study, New Zealand, looking at differences in part of the genetic code thought to influence transmission of serotonin. Right, so they're able to identify, okay, here's this one area of the genome that we think is related to how serotonin is transported in the body. So you can have this type of gene or this type of gene. Right. Certain types of genes, or alleles, as we say, are associated with higher rates of depression, which is what they would kind of expect if there was a genetic thing. So again, with these genes, you have kind of two alleles that they're looking at, and they can either both be short or both be long, or one short and one long. Right? And generally, having the longer allele was thought to be better, related to better serotonergic functioning, okay, which they found. Right? So having short alleles was associated with higher rates of depression, but only for people who experienced more negative life events. Right? So if we look at this graph here, we have different variations of measuring depression. We have self-reported depressive symptoms, probability of a major depressive episode, probability of a suicidal ideation or attempt, informant reports of depression, so other people saying how depressed they were. All four graphs here measuring depression, and generally showing the same type of trends. We'll just look at the first one, look at A, how depressed people say they were. So you have that one line, SS, that's if they had two short alleles. And then the lighter colored line below it, they had one short allele, one long allele, and then the dotted line below that, they had the two long alleles, the good genes, right? So along the y-axis, the vertical, is how depressed they were, and along the x-axis, along the horizontal, number of stressful life events. So if we go all the way to the left and look at if they had people who reported no stressful life events, right? Hey, life is good, nothing bad's happened yet. there are no differences between people with the short alleles, two shorts, short and long, or the double long. Right? Everybody's like, I'm not that depressed. As the number of stressful life events increases, only then do we see these populations spreading apart, with people with those two short alleles experiencing more depression. Right? So, if we could make everybody's life easy and not stressful, we could eliminate depression regardless of genetics. Theoretically, everybody would look the same. That's kind of what these data are telling us. So we could nullify the importance of genetics if we fully manipulated the environment. Right? But given that we can't fully manipulate the environment, pre-existing genetic factors are going to predict, not necessarily cause, we don't know for sure, but we can say they will predict these differences in depression as the number of stressful life events increases, right? Which is fascinating stuff. Okay, into phenotypes. Genetic researchers often struggle to document what they believe to be true, largely because they use these we use these messy diagnostic categories as variables. More recent research has started looking at using knowledge about genetic relatedness. Siblings, non-twin siblings versus monozygotic twins versus dizygotic twins versus grandparents or degrees of genetic relatedness. Looking at this to predict important endophenotypes. So instead of trying to predict disorders, predicting these things in endophenotypes, which are basic traits that are involved in disorders. Right. So the tendency to experience dysphoric mood. Right, so instead of looking, if you have these genes versus these genes, do you have dysthymic disorder or not, or major depressive disorder or not, right? When we look at these kind of categorical variables that are not always super reliable, and they're definitely categorical, which gives us a limited amount of variability, which is bad when trying to predict things, it makes it hard to find stuff. So they said, well, instead of looking at disorders, let's look at kind of the key parts of the disorder. So the tendency to experience dysphoric mood, which can be measured on a continuum. We can account for more variability there. It's a more promising area of research here. So that may be where we really figure out about the role of genes when we stop looking at the relationship directly between genetics and disorders, and instead between genotypes and endophenotypes. Okay. Other biological factors, neurotransmitters, play a role in everything you do. The key here is it's not about simply an imbalance of neurotransmitters, too much or too little. It's like, oh, you don't have enough serotonin, let's give you some more. Oh, you have too much, let's take some out. It's not that simple. But we do know that they play a role. And the primary culprits in mood disorders are serotonin, dopamine, and norepinephrine. Other neurotransmitters play a role too, but these are the major players. And we know that largely because drugs that we know target the functioning of these neurotransmitters have an effect on mood. Right? For serotonin, there seems to be differences in serotonin receptor sensitivity related to depression. Right? So people who experience depression may need more serotonin neurotransmitters floating around in their synapses to get the same amount of neural activity as other folks. Right? Because again, the neurotransmitter is released from one synapse, floating across synapse, attaching to the next one, causing that cell to fire. The idea being that it's not that you have too much, too little serotonin, but that, your particular brain cells that are using serotonin to communicate are insensitive. They're not as responsive. And so because of that, you need more serotonin in the synapse to cause that cell to fire. And if it's the cell that's associated with activating the happy part of the brain, which is a gross generalization, but I said it anyway, that may be what's part of what's going on. And kind of the head part of the brain seems to be related to not so much, when this part of the brain gets activated, I'm happy, but rather, this for serotonin, serotonergic activity seems to influence our ability to inhibit attention to negative stimuli. Serotonergic activity seems to influence our ability to inhibit attention to negative stimuli. So that means that when life sucks, bad things are happening, right? And usually when that happens, good stuff's happening too. Life is a mix. Right? but sometimes it's hard to focus on the good and not so much on the bad. And this is one thing that serotonin seems to play a role in is when we want to focus on the good and not pay attention to the bad, directing attention away from negative stimuli seems to be related to serotonergic activity. Where and we know that largely from impairing people's serotonergic functioning, then they have a hard time not paying attention to negative stuff. That may be part of it, right? Which again makes sense if you think about CASPI study and the role of negative life events. It's where bad things happen. It's harder not to think about them and harder not to feel bad if you're not if your serotonergic pathways aren't as efficient as other people. Right? But again, if you don't have bad things happening, it doesn't matter if your serotonergic pathways aren't all that great, because generally you're going to be happy until bad stuff happens. Dopamine plays a role partly because we know serotonin influences the transmission of dopamine. It's kind of thing about if your brain were a computer, all the wires are crossed, right? They're bare wires in places touching, where activation of one wire activates or deactivates another wire. Right? But we know that too much dopaminergic activity is related to mania. We can make people look manic by souping up their dopamine, giving them a lot of L-dopa. And too little is generally related to depression. And we also know that dopamine plays a big role in our reward systems, feeling good, right? So, taking cocaine, it's going to be hitting your dopamine receptors. So for those reasons, we think, okay, well, dopamine is probably playing a role in mania somehow. Don't really know why. But even more mysterious is norepinephrine. It doesn't seem to be involved in the origins of mood disturbance so much, but it may play a role in their maintenance. Right? Norepinephrine pathways often provide links between serotonin and dopamine pathways. And we know that chronic stress, which is associated with the release of cortisol in the body, negatively impacts the functioning of norepinephrine. Right? And if once that gets sidetracked by kind of cortisol, that may then negatively impact serotonergic functioning and dopaminergic functioning. So again, a lot of us still trying to figure it out, and unfortunately, we figure it out by trying drugs and see what happens, given what we think how the drug works. Unfortunately, people often respond differently to the same drug because the brain is complicated. The neuroendocrine system also playing a big role in mood disorders. And the neuroendocrine system, again, is kind of this idea for the interactions between the central nervous system, right, brain, spinal cord, and the endocrine or glandular system. Looking at the HPA, the hypothalamic pituitary adrenal axis, so hypothalamus, pituitary, and the adrenal glands, those things together. And cortisol. The HPA axis is involved in the production and dissemination of cortisol, and that's a hormone that gets you ready to respond to threats. Right, it's the stress hormone, which you need some of it, right, to get you going, but too much seems to be a bad thing. We also know that the HPA axis gets stimulated by the amygdala. So whenever threat signals in the brain activate the amygdala then activates the HPA axis. Then the hippocampus tells it when to shut off. So, okay, threat's gone. Okay, so keeping all that in mind, we'll think about Cushing's disease. Right? This involves problems with pituitary that lead to too much cortisol. And this disease is associated with high levels of depression, which was our first piece of big evidence that stress and cortisol may play kind of a causative role in development of depression. And since then, we learned that chronic cortisol production is associated with decreased serotonergic activity. So the serotonin pathways are lighting up less if you've had a lot of cortisol in your body for a long period of time. So basically, the more stress you experience biologically, not just psychologically, but biologically, whenever that psychological crosses over into the biological kind of chemical phenomenon, the less well prepared your brain is to deal with more stress. And as that happens, we see the serotonin activity getting screwed up and maybe putting you at risk for things like depression. Okay, in terms of early experiences, it's also possible that some early negative experiences will have a greater effect than if they had happened later in life. And this kind of harkens back to kind of a psychoanalytic Freudian stuff. Well, oh, childhood is what's all important. And there may be something to that. Not necessarily for the reasons that Freud and people said, but just because the rapid period of brain development in youth is different than brain development in adulthood. And your brain continues to develop in adulthood and is always changing and developing. But it's not changing as quickly as when you're younger, especially very young. First 3 months of life, a tremendous amount of development. So early negative experiences, thinking about things like abuse, caregiver abandonment, those types of things may have a greater impact on mood disorders if they happen early because the brain's still forming. So if the brain's figuring out how to wire itself and you're experiencing kind of high levels of stress and cortisol early on, right? The brain is more vulnerable, think of it that way, more vulnerable when it's younger and still forming than when negative life events happen later in life. Okay, so most things I talked about here for biological factors, with the exception of genetics maybe, most of the evidence is about depressive episodes, more so than manic episodes. And I think the reason for why there's more kind of stuff to talk about, more research on what causes depression than what causes mania, is because depression is much more common. Remember, think about how the 17% for manic depressive episode versus, 1.5%, much lower percentage for bipolar 1. So there's more people out there to study who are depressed than who are manic. Okay, in terms of social factors, negative life events, we just talked about that. The Caspi study definitely showed that they play a role. Negative life events seem to be more influential on the first of a person's mood episodes than later ones. So you're going through life, everything's kind of copacetic, something bad, something good, whatever. There's a major life event that may put you at risk for a mood episode. After you've had that first one, now you seem to be at risk for more mood episodes, even if your life tends to become more stable. Right? So the role of negative life events seems to be really on the development of the pattern, starting, but not necessarily after that. The pattern's been developed, and your brain's kind of you've dug new rows that it's going down now. For depression, loss seems to be the most important event for triggering depression. Whereas mania, it's schedule disruption and or goal attainment. So schedule disruption being a lot of times very kind of biological circadian rhythm type things. People that go on shift work, where they have to change their schedule of when they sleep and when they're eating, that may be associated with triggering mania. Also just kind of being in one routine always and then suddenly having to do something totally different for some reason seems to be may trigger the first manic episode. But also goal attainment. So something good happening, getting a promotion at work, may be what triggers the first manic episode. It's also important to consider the meaning attributed to the stressful life event, and that's why the same life event will affect two different people differently. Right? This may be related to how they think about the event, whether or not the loss or change was personally significant. So, if they lost their job, how important was that job to them? How much was it part of identity? And those types of differences may be associated with why one of them gets depressed and the other doesn't. So the event isn't enough in itself. It's really important, that kind of cognitive thing about, well, what did it mean to them? What did they think about the loss or the change? The stress generation effect. Some of the negative life events may be related to things they do to themselves, possibly as a result of a mood episode. This is the idea that some of the stress in one's life may be self-generated, and once you have it's kind of the vicious cycle idea where you have your first major depressive episode for whatever reason, and you get lethargic and you pull back from life and you have difficulty concentrating, all these things. When that happens, it's going to be difficult to fill your major role obligations, right? So in terms of being a spouse or partner, a parent, a worker, a student, whatever. And if you're not able to do those things, depending on how supportive your environment can or will be, you may end up incurring other stressful events because of the mood symptoms, right? So events can lead to the mood symptoms, and the mood symptoms can then generate more stress, which can then perpetuate the mood symptoms. Related to that, lack of social support seems to be important. For whatever reason, we seem to be wired to be social creatures. And so people who have lower levels of social support are more likely to experience mood disorders. Other social factors somewhat related to social support here. Low rates of positive reinforcement, very kind of behavioral view here. This is Lewinson's theory, that when people do things that typically result in positive reinforcement. So typically I work hard to get a raise, but if they develop that pattern, right, they have expectations, but if it doesn't happen, so things they typically do that lead to positive reinforcement, but they don't get the positive reinforcement, work really hard, no raise. You know, I really did a lot of stuff for this person, and then they didn't do anything for me back, or they didn't help me one time I needed them. That experience leads to dysphoria, right? Kind of negative mood. People mope around, and then the social environment reinforces your moping because they feel sorry for you, like, oh, are you okay? Then your moping will contribute to ongoing low levels of response contingent reinforcement. So you'll no longer try to get the good things. It's almost like you've learned not to. Okay, so and that may be where the social factor comes in, where you don't get rewarded for what you want, change the way you act, and then this kind of new way of not trying and being sad gets rewarded, and so you stop trying to get positive reinforcement. And without positive reinforcement, more likely to experience depression. Social rejection. Coyne focused on the impact of these behaviors we just talked about with Lewinson on interpersonal interactions, suggesting that the moping is done in order to connect with others, like, oh, I'm sad, and trying to pull people in. But eventually what happens is, you may get this initial response, but eventually that it leads to rejection if we don't brighten up pretty quickly, right? The idea being that people will initially be nurturing, but only for so long. Right? And other research and theorists agree with the importance of social rejection in the etiology, but feel that instead the rejection comes from not necessarily the response to the moping, but from a deficit in interpersonal functioning. That people who have impaired social skills in whatever variety of ways are more likely to experience social rejection, and then that social rejection will then lead to depression. So how would you help prevent depression? Teach people at a young age positive social skills, right? How to relate to others in meaningful ways. In terms of cognitive factors, the major theory here would be Beck's cognitive theory of depression. Right? Talks about a couple things. One, self-schema, right? The idea that we all have certain beliefs about ourselves and tendency to interpret information about ourselves in a particular way. So a schema about the self, right? This kind of cognitive structure that influences, it's informational, it's what we know about ourselves, but it also influences stuff that comes in. When people say stuff about us, positive feedback, negative feedback, it gets interpreted through our self-schema. Okay? So these beliefs and processes, which are these beliefs and processing proclivities that make up our self-schema, are very powerful. And we know that from things like the cocktail party effect. You're at a party, people are talking, somewhere across the room somebody says your name and you turn, what? Right? We are sensitive to information about ourselves. Okay. Beck theorized that the experience of depression, which is an emotional, physical, cognitive phenomenon, is brought about by a depressive self-schema. That people develop negatively themed beliefs about themselves and a tendency for negative self-appraisal. So I'm bad, the knowledge is that I'm bad, and then also the negative self-appraisal. When stuff comes in, I'm looking for the bad and I'm ignoring the good, right? Especially related to failure to attain certain goals, right? If something bad happens, I don't get what I was trying to get, it's about me being not good enough, about me being bad. And that these developments are due to interactions that occur during development, right? And when's development? Well, always, right? So at some point, as you're growing as a person, you're developing this idea of yourself. And schema are always open to assimilation and combination, right? They can be changed, but the longer you have a schema in place, the more resistant it is to change. Okay. Beck's cognitive triad suggests that these depressive schema influence people's perspective in 3 areas. So kind of the way the scaffolding in your mind that you build affects the way you view yourself, I'm bad, the world's a dangerous, uncaring place, and the future. The future is bleak and there's no hope of changing it. And people that are experiencing a major depressive episode tend to have these types of thoughts. So you can reliably distinguish between somebody who's depressed and not depressed based on, okay, do they have these negative thoughts in these areas? And when there's debate about this the debate is, okay, well, do the thoughts come after the depression or before? So is it, oh, you're thinking this way because you're depressed, or is it you're depressed because you're thinking this way? And it's probably a bit of both, right? And if we make people think negative things about themselves, they'll feel worse, and we can do that in kind of controlled ways. But also, once they start feeling worse for other reasons, so if you have like Cushing's disease, you also tend to have these negative thoughts afterward. The third thing that Beck's theory of depression, cognitive theory of depression, touched on is these cognitive distortions, right? So the cognitive triad is about beliefs in the schema. Cognitive distortions are about the faulty cognitive processing tendencies. Faulty cognitive processing tendencies, which is a fancy way of saying crooked thinking, right? Where these tendencies, these ways of thinking, that crooked thinking, tend to distort incoming information to be consistent with the negative self-views, right? So I'm bad, the world's bad, the future's bad, and so cognitive distortions are when stuff comes in, you have a way of distorting that that knowledge, that information, those data, to be consistent with your schema, so your schema doesn't have to change. Because again, schemas are difficult to change, right? The way people see the world is difficult to change. The way you see yourself can be changed, but it's difficult. It's resistant, right? Because if you consistently change the way you saw yourself every time somebody said something about you, you would have no sense of self, right? So it has to be stable in some senses. But when it's stable and negative, it may cause problems. The cognitive distortions we talk about are things like catastrophizing, selective abstraction, focusing on the negative and generalizing. So catastrophizing, probably one of the most common ones. That's whenever something comes in and it's maybe a slightly negative event. I failed a quiz. Oh my God, I failed this quiz. I'm such an idiot. I can't do anything right. I'm probably going to fail the next quiz and then probably the test. If I fail the test, I'll probably fail this class. If I fail this class, I'll probably fail my other classes. If I fail all my other classes, I'll lose my financial aid. Lose my financial aid, I'll have to pay this back. I won't have the money, and I'm going to lose my house. I'll lose my house and be homeless on the streets. Right? And so from failing a quiz, you go to being homeless on the streets, begging for heroin. Right? That's catastrophizing, taking one kind of negative event that's, may truly be not a good thing, but blowing it out of proportion to this catastrophe. Right? So going down that cognitive spiral to things are worse and worse and worse and worse. Another kind of helpful way of thinking about the cognitive factors associated with mood disorders, particularly depression, are the attribution-based models, which focus on one aspect of cognition, and that's the explanations people make for successes and failures. Seligman's theory of learned helplessness has been used a lot in this field. This is based on his work with dogs, right, where you have these dogs, and you can teach them. You have this large cage, right, and part of the floor on the cage, the grid, is electrified. You turn it on, shocks, hurts, but they can jump off that part onto another part, and they're fine. Right? Or they can push a button and it turns off. And you do that to dogs. They don't like it, but they don't get depressed. Now, teach dogs that, and then whatever they did to turn the shock off, if it's push a button, move to the other side, you no longer turn the shock off. So they move to the other side and it still shocks them. So they can't avoid the pain. They're helpless. And you say, well, that's not very nice. No, it's not. But it did lead to some important insights into possibly how depression is influenced by cognitions. You do that, and then you stop doing that. So you go back to the original thing where you shock them and they can turn it off. All they have to do is move to the other side. What he found was the dogs wouldn't do it. They would lay there and take the pain. And the only way to get them to do it would be to physically pick them up and move them to the side, or take their paw and hit the button, whatever it was. And after that, then they could do it again. But they had to be almost like they had to have their hand held and show that, oh no, it doesn't have to hurt. Right? So there's this idea that kind of blow that out towards humans. When bad things happen, and there's nothing you can do about it, you try to do stuff, you try to make it better, and it doesn't work. It's a sense that I give up. I can't do anything. And then and it may be in that situation, they've turned the shock on and nothing you can do will make it better. But in life, it's not stable, right? At some point, you could exert your agency and make changes to make things better. But if you've learned in kind of a very profound and maybe an unconscious way that there's no use in trying, then now whenever that good thing is right around the corner, you're not going to go around the corner to do it. You're not going to take the chance to get that job, ask that person out, whatever it is, because of this sense of learned helplessness. Right? And the other thing about this, not only is it about not trying, giving it motivation, the dogs looked depressed when this happened to them, right? They were lethargic, they had decreasing appetite, a hard time sleeping. So a lot of the kind of somatic symptoms of depression, they're able to induce with this kind of learned helplessness paradigm. Okay. The other attribution-based model has to do with attribution style. And this comes a lot from Wagner's work, looking at when negative things happen, negative events. How do you explain them? And it has to do with the locus of the explanation, the stability, and the specificity. So the locus, either internal or external. So people are more likely to experience depression. If something bad happens, it's because of me, right? So I failed that test because I'm stupid, not because the professor sucks or the test was unfair. Saying it's unfair, the test was unreliable, and it's not about me, it's external. And you can argue about, well, should you take responsibility, should you not? This is just about depression. If you make internal attributions for failure, more likely to experience a depressed mood. And then stability, stable versus dynamic, right? So I failed because I'm stupid and I'll always be stupid, versus I failed. So it couldn't, if it's internal and stable, now we're kind of making it worse. If it's internal but not stable, not so bad. So we can say, oh, it's my fault, I didn't study enough, but I can study more next time. Okay, well then it's not less likely to be depressed, right? But if it's internal and stable, so it's my fault because I'm stupid and I'll always be stupid. No amount of studying can change that. Okay, now looking not so good. And then the specificity, a specific cause versus global cause. I failed that quiz. Man, I'm stupid. I really suck at, calculus. I'm never going to be good at calculus. Okay, and that's not that great, but that's better than, in terms of depression, I'm so stupid. I suck at this. I'm always going to be stupid. I'm stupid at everything. I can't do anything right. So a global attribution. I'm bad at everything versus I'm bad at this one thing that this thing tested. Okay, so the more of these things you have, if it's internal, stable, and global, now we've increased the likelihood of experiencing depression in response to that. And again, people that are depressed tend to have those type of attribution styles. Okay. So, summing up, the major primary mood disorders: major depressive disorder, a major depressive episode, and no other episodes. Bipolar disorder, 1 or 2. 1 is manic and then something else, maybe not. All you have to have is a manic episode. 2 is a major depressive episode and a hypomanic episode with never manic or mixed. Dysthymic disorder is kind of, again, like that chronic depression. Cyclonic being chronic mood fluctuations, more like bipolar disorder. So when diagnosing mood disorders, you need to know what the current mood episode is, and also what other mood episodes they've had. And if it's the first time they're seeing you, they may not be able to tell you, oh yeah, I've had a manic episode before. So you have to ask about, was there ever a time in your life where, and then you describe what that mood episode is like, right? And you try to describe it in kind of normal terms, and not use kind of DSM funky language. And you also need to assess whether or not psychotic symptoms are present now, or if there's history. And then if so, do the psychotic symptoms occur only during a mood episode or not? And that's going to have to figure out if it's a mood disorder or schizoaffective or a psychotic disorder. Okay, that's it.